Hi everyone, my name is Saeed Hashim. I am a board certified geriatric psychiatrist working in the outpatient division at McLean Hospital. I am also a clinical researcher within the geriatric research program at McLean, and I work as a clinical instructor of psychiatry at Harvard Medical School. And today I'm going to be talking about major neurocognitive disorders, offering an overview that should be helpful for primary care providers, nurse practitioners, physician assistants, residents, and young learners caring for older adults. So I have to acknowledge that this presentation is supported by the HRSA grant from the US Department of Health, but the contents of the slides that I'm sharing over this course only represent me and do not represent the official opinion of the US government or the Department of Health. I do have some conflicts of interest that I should share, that I work as a co-investigator on active clinical pharmaceutical trials with Biogen and Eisai, investigating the use of monoclonal antibodies in MCI and early Alzheimer's disease. I'm also going to be discussing some off-label therapeutics for Alzheimer's disease and related dementias that were discussed in published medical literature. So in order to stick to our age-friendly health system initiative with the famous 4 M's that we follow through our work, I want to emphasize that during this course, I'm going to be focusing more on what matters and mentation for older adults. So let's talk a little bit about the history and some of the definitions in the neurocognitive disorders space. So here's a historical perspective. Dementia has been always recognized as a medical condition for many centuries, and it describes a range of symptoms that are mostly related to cognitive issues. It comes from the Latin word demens, which means losing the mind. And in ancient times, dementia was often attributed to supernatural causes or just considered a normal part of aging. So the history goes back to the 7th century BC when Pythagoras divided the human lifespan into 6 distinct phases: infancy, adolescence, young adulthood, middle age, old age, and then advanced age when we're talking about above 80 years old. 63 to death was labeled as the phase of senium, and that's how the word senility was derived. He described this senium as the scene of mortal existence, closes after a great length of time that very fortunately few of the human species arrive at, and where the mind is reduced to the imbecility of the first epoch of infancy. So he's describing some sort of regression in the cognitive faculties as you enter this phase after 63. And then in the 17th century, English physician Thomas Willis first described dementia as a medical condition caused by brain damage rather than just a part of normal aging. In the 20th century, we saw significant advances in research because of the advancement in pathological sampling, how we preserved brain tissue, which led to further discoveries. So in 1906, the German psychiatrist Alzheimer discovered the presence of unusual clumps and tangled fibers within brain neurons. And thanks to Ronald Reagan, Alzheimer's disease gained further recognition and momentum in funding that helped us a lot to spend more time studying how to diagnose and treat such a disease. So today, the term dementia is still used among the medical community as a very collective term, but in recent classification, we now use neurocognitive disorder to describe this constellation of symptoms and reduce the negative connotations associated with the word dementia. So now in our current classifications, neurocognitive disorders is basically a category of mental health disorders primarily affecting cognition, and they are classified into 3 main chapters. One is delirium, two is the mild neurocognitive disorders, also known as MCI or mild cognitive impairment, and then the major neurocognitive disorders, what we used to call dementia. The DSM-5 defines 6 key domains of cognitive function that we use to describe these disorders, including executive function, learning and memory, perceptual motor function, language, complex attention, and social cognition. So let's first start with delirium. Delirium is definitely a medical emergency characterized by sudden and severe disturbance in the person's mental abilities. It's basically an acute confusional state that develops quite rapidly over hours or even days, caused by an underlying medical condition in most cases, such as an infection, a dehydration, or a drug toxicity. Advanced age, hospitalization, and chronic medical illness are major predisposing factors. So older adults are at definitely much higher risk than younger populations to develop such a condition. It is characterized by disorientation, inattention, hallucinations, and a change in their sleep pattern are common. So they may have a reverse sleep rhythm where they are more agitated at night and more sleepy during the day. Based on their motor activities, it could be classified as hypoactive or hyperactive delirium. And in general, treatment is always targeted towards addressing the underlying cause. So let's move on to the mild neurocognitive disorders, also known as MCI or mild cognitive impairment. So what is mild cognitive impairment or mild neurocognitive disorders? It's basically a condition that involves a decline in cognitive function that is still greater for what we expect for somebody's age and educational level. And if we want to quantify it, we typically look at a deviation that is more than 1.5 standard deviation below the normative expectations. And it's not severe enough to interfere with daily activities, and that's a key criterion. Individuals can usually compensate for these difficulties with the help of some strategies and support from others, so they may require some reminders. They might write things down using lists, using technology to cover up for their mild deficits. And a key component here again that it should not interfere with the daily activities. So who is more likely to develop such a disorder? We're talking about aging, hypertension, diabetes, patients with heart disease, and mental disorders like depression or anxiety. They are usually classified either into amnestic versus non-amnestic based on cognitive deficit focused more on memory problems, or they can be classified as progressive, non-progressive versus reversible. So reversible if there is an underlying reversible cause, which we will come to later on, or a progressive, which is usually a degenerative disease, versus a non-progressive, which could be caused by a head trauma, anoxia, or a vascular insult. So when it comes to amnestic mild neurocognitive disorders, it could be actually an early sign of Alzheimer's disease. So the patient might experience such a symptom and then things progress into full-blown Alzheimer's. Some may experience stable or even improved function over time, depends on the underlying etiology. If it was reversible or vascular, things may stay stable. Management usually includes just monitoring them and non-pharmacological treatment. However, that may change in the future as we discover more therapeutics targeting at disease modifying. We may think about intervening at this stage before it converts into Alzheimer's. So how common is the mild neurocognitive disorder? So the epidemiology is usually understudied because it doesn't even interfere with their day-to-day activities. It's hard for them to come forward and see a clinician and say, hey, I'm having a problem. But a meta-analysis in 2022 showed that for those who are 50 years or older, worldwide, the overall prevalence is somewhere around 15%. The prevalence rate of amnestic MCI is around maybe 10%, and the non-amnestic MCI is less prevalent. The prevalence is usually affected by age, gender, education level, and region of the study site. Let's talk about major neurocognitive disorder, which is the bulk of our talk today. So major neurocognitive disorders, how do we define them? As opposed to how we just defined mild neurocognitive disorders, Major ones are usually a serious decline in the cognitive function that affects the person's ability to perform daily activities. And on normative scores, we expect a deviation for more than 2 standard deviations from the normative values. The symptoms are usually gradual, progressive, leading to significant disability and somewhat loss of independence. There are so many types of major neurocognitive disorders, but Alzheimer's is the most common type. Diagnosis is usually based on a comprehensive medical, neuropsychological evaluation, and brain imaging to look for biomarkers. So back to the DSM-5 criteria, when it comes to major neurocognitive disorders, it requires a significant cognitive decline in at least one cognitive domain as determined by the clinical evaluation and standardized testing. It's preferably to have both. It should be severe enough to interfere with independence in daily activities. It should not occur in the context of delirium, and it should not be better explained by a mental disorder or the effects of a medication or a substance. And there should be an evidence of a cause that we can think of, like a medical condition, Alzheimer's disease, Parkinson's disease, Huntington's dementia, frontotemporal dementia, vascular dementia, TBI or HIV infection, among many other causes. Okay, so let's sit back and take a moment and think, why are we discussing all of this? How expensive this disease can be and what's the burden of it worldwide? Why is it so important to learn about these conditions? That takes us to the epidemiology of major neurocognitive disorders. So the epidemiology of dementia is pretty important because in 2021, we recorded 55 million cases worldwide, and that number is expected to triple in just 30 years, with 2/3 of cases will be in low to middle income countries. We also estimate that 10 million new cases per year will be diagnosed, and the prevalence does increase according to the age group. So it ranges from 3% of those who are between 65 and 74 up to 1/3 of the individuals aged 85 or above. It was found to be slightly higher in women versus men, and the median time from diagnosis to death also depends on the age at diagnosis. So you're talking about 6.7 years of people diagnosed below 70 and only 2 years for people diagnosed at 90 or older. And that is important to estimate how many years of lost functioning we're talking about, especially when we're having an aging population worldwide. So what about the United States? So the Alzheimer's Association stated that we have around 6 million Americans who have Alzheimer's disease in the United States. Most of them are women, and it's projected to also triple to up to 14 million cases by 2050, in 30 years from now. And the prevalence is very similar to how it is worldwide, where we see around 5% among those aged between 65 and 74, up to 1/3 of those who are aged 85 and above. African Americans and Hispanics are at higher risk than whites, and they are less likely to receive a timely diagnosis. The CDC puts Alzheimer's disease as the 7th leading cause of death among all age groups and the 6th leading cause of death in older adults, meaning 65 and above. So let's move on to discuss how major neurocognitive disorders in general present in the clinical setting. It can be highly variable. It can be quite subtle, masked by a caregiver or living arrangement that may not expose all the deficits that a person may have. Most types are gradually progressive, and the onset is usually weeks to years after the actual cause of neurocognitive disorder. So let's talk first about cognitive symptoms of major neurocognitive disorders, which should affect any or all of the 6 cognitive domains defined by the DSM. Memory loss is the most common, but it can also affect language, social cognition, inattention, perceptual motor dysfunction, and executive function. There are also behavioral or neuropsychiatric symptoms of major neurocognitive disorders, and these are usually in 12 categories. One is apathy, which is the most common, depression, anxiety, hallucinations, delusions, irritability, agitation, disinhibition, mania, aberrant motor behaviors, and sleep and appetite disturbances. What about cognitive symptoms? So it depends on which part of the brain is affected by the disease, because each lobe has its own function. So as you can see in this simplified diagram, the frontal lobe is more concerned with executive functions, affect, social cognition, and personality. The parietal lobe is more focused on visual information processing, spatial orientation. Visual perception is the function of the occipital lobe, and the temporal lobe is where most of the memory functions are, language production and language comprehension. So cognitive symptoms, when it comes to learning and memory, anterograde amnesia is the most common. It usually affects short-term memory much more than it would do for the long-term memory. Difficulty learning new simple skills. So if you switch to a new TV, a new microwave, or a new phone, they have significant difficulty learning the new one. Forgetting to buy familiar items like grocery, missing bills and paying them after when they are due, buying the same items more than once. You go to the grocery store, buy something because they think it's missing from home, they go back and realize they already have it. Repeating questions over and over, which can be annoying to caregivers. They have difficulty recalling recent events or conversations. They may rely excessively on lists and reminders. They can mix timelines. They cannot really tell you a sequence of events properly, and they tend to misplace objects frequently. What about inattention? So tasks may take longer than what it used to be. They can get easily distracted by multiple stimuli in the environment. They have difficulty holding on information for calculation or manipulation. So you give them a simple math equation, they cannot hold the numbers long enough in their head to make the calculation or dial a phone number. Work requires more revision and supervision than it used to be, and they have difficulty concentrating or staying on task. They just get distracted. Language. Language, most common symptom is difficulty finding the correct word, difficulty naming objects and people, mispronunciation of some words. They may have some major syntax errors when they write or talk. They have difficulty understanding written and verbal communication in severe cases. Executive dysfunction. So that means that they may have difficulty completing familiar multi-step tasks. They may avoid house chores, especially cooking. They have difficulty planning, difficulty packing for travel, difficulty following a series of directions, difficulty shifting conversations, difficulty making a choice, and difficulty solving their day-to-day problems. What about perceptual motor, which means also visual spatial? That means that they get lost in familiar environments. It may show as difficulty using familiar appliances or tools, so they hold it and they do not know how to manipulate it properly. They may have difficulty driving and understanding directions. They may have difficulty gauging distances if an object is close enough or far enough. And that also shows when they try to put something together or draw on a piece of paper. Social cognition gets impaired, so they would make like gaffes or inappropriate behaviors. They may have poor judgment calls in social settings. They may have limited perception of social cues if somebody around them is annoyed or happy or displeased. And they have impaired empathy, so they do not react as they used to pleasant or unpleasant news. Let's talk about neuropsychiatric symptoms, which is a very important part of major neurocognitive disorders and a major cause of caregiver burden. So the first and the most common one is apathy, where they lose interest in the world. They lose interest in things that they used to enjoy. They do not maintain motivation to start new activities. They are much more difficult to engage in social settings, and they are less likely to initiate a conversation. It is very common in dementia and among the hardest symptoms to treat. Depression. They can get tearful, hopeless, acting in low spirit, feel like they are a burden and deserve to be punished. Sometimes it gets bad to the point that they have death wishes and think about hurting themselves. This symptom is usually more common earlier in the course of the disease, especially if they recognize that their cognition is not what it used to be. Anxiety. Due to their awareness of the change in their cognition, they can get quite anxious, very worried about planned events, unable to relax even in usual pleasant settings. They can get panic attacks and get quite nervous when they are separated from their caregivers. Hallucinations. These are particularly more common later in the course of the illness. They may describe hearing voices or act as if they are hearing voices. They may talk to people who are not in the room. And similarly, they may see, smell, feel, taste things that are not there. Among all these hallucinations, the visual ones are particularly more common. Another concerning neuropsychiatric symptom is delusions, which are defined as false, fixed beliefs that you cannot refute despite clear evidence. So they may start believing that physical danger is imminent, that somebody is trespassing in their property, that their spouse are cheating on them. They believe others are stealing from them, especially when they misplace their objects too often. Instead of thinking, oh, I may have misplaced it, they would think, somebody's stealing from me. They may start thinking that family and their partner are actually imposters. Or this is not my home, I need to go home when he's actually at his residence. They may think that family will just abandon them and leave them in a nursing home and walk away. And sometimes they may start believing that the TV characters or the ones that you see in the newspapers are actual figures living or existing in their own physical space. And that could be also enhanced by how high definition the TVs have been recently. The content of the delusions in dementia tend to change from time to time because their memory doesn't hold on to the system that they have created for too long. Our next symptom is agitation or aggression, and that usually manifests in resisting doing some activities, especially taking meals, accepting medication, and bathing. They can get a little bit hard to handle, and caregivers would describe them as uncooperative. It can be verbal, and in worst cases, it could be physical. Next is irritability. And when we talk about irritability, we're more focusing about their mood, their temper, rather than their behavior. So with dementia, it can come in bouts. They can present as cranky and impatient, so they ask for example, to be fed or to go outside, and the caregiver would say, wait a minute, I'll attend to your needs, and they get immediately upset and angry. They cannot cope with delays. It may present as sudden flashes of anger that go away quickly, but may be happening too often and quite burdensome to caregivers. Next is mania, which is basically being too happy for no reason or laughing at things that are not actually funny. It may manifest as childish sense of humor or too giggly. Some patients may do some practical pranks on their family members or present as a bit grandiose. disinhibition, meaning that they become a little bit more impulsive than their baseline, socially unconstrained, again, compared to how their character before the disease. They make some crude or sexual remarks to strangers, sharing very private matters with total strangers, and a tendency to hug or touch others without permission. Next is aberrant motor behaviors that are mostly increased motor activity that doesn't really have a purpose, including pacing, fidgeting, packing and unpacking either bags or drawers, increased rituals that, again, are purposeless, changing their clothes and outfits too often, picking on buttons, threads, and maybe items around them. In severe forms, it may show some wandering behavior where they decide to go outside and just keep walking. So the last two that we have to discuss here are sleep disturbances and appetite disturbances. So when it comes to sleep, they may suffer from difficulty falling asleep, nighttime pacing, waking up in the middle of the night thinking it's a new day and they are ready to go, or waking up too early in the morning thinking that it's 10 a.m. when it's actually 4 a.m., or excessive daytime naps. So when it comes to their appetite, they may show increase or decrease in their appetite, which could lead to some loss or gain in their body weight. They may show some changes in their feeding behaviors, in the way they manipulate their utensils, the way they choose their food, what type of food they're consuming. In severe cases, they might consume inedible stuff as food, like ketchup or wood splinters or pencils. And sometimes we see a change in their food preference, as in craving too many sweets, one of the more common ones. So after viewing several symptoms of major neurocognitive disorders or dementia, I invite you to take a deep breath and think which one of these symptoms might be the most problematic for patients, and which one of these symptoms might be the most problematic for caregivers. Next, let's talk about how we stage neurocognitive disorders. So this simple diagram should help you understand how major neurocognitive disorders or dementia progress. So it usually starts by a preclinical phase where there are some brain changes and the patient may notice that something is different about them. But when we do history taking, physical exam, cognitive exam, we can't really detect measurable deficits. And then MCI follows, where we notice difficulties in some cognitive domains, one or more, that we could measure on testing, but it has not affected the patient's ability to function independently. And then dementia comes after, as we had described in previous slides. So allow me to break it down a little bit further, talk about pre-dementia and then different stages of dementia. The pre-dementia is essentially the mild cognitive impairment stage, which can be easily missed, usually diagnosed in retrospect after dementia had already started. Deficits are not severe enough to affect daily functioning, and that's why they do not present soon enough to their doctors. Episodic memory recall, which is short-term memory in other words, and word-finding difficulty is a common presentation. Around 15% of those individuals will end up developing dementia each year, and a third of those with amnestic MCI develop Alzheimer's disease within 5 years. This stage is ideal to establish the advance directives and protect the person's wishes regarding their care, including end-of-life care, before their cognition starts to deteriorate further, making this process much more challenging. So in early dementia, symptoms becomes more noticeable even to others around the patient. It starts interfering with daily activities, and on the mini-mental status exam, the score's somewhere between 18 and 24. Early symptoms are dependent on the type of dementia. So for example, you see more memory problems with Alzheimer's disease, more executive dysfunction with vascular disease, more behavioral changes with Lewy body dementia and frontotemporal dementia. They may need assistance and reminders with some or many tasks, and patients are usually aware of these deficits, leading to frustration, anxiety, or depression. Sometimes they become quite angry, either with themselves or with their caregivers if they start correcting them too often. Next is middle or moderate dementia, where the initial symptoms that we mentioned on the previous slide start getting worse. Scores on the cognitive testing will start falling between around 10 points to 17 points out of 30. Patients cannot usually function outside their own home and generally should not be left alone at this stage. Simple tasks might be still doable, but the instrumental activities of daily living require thorough assistance or very close supervision. Patients typically lose insight into their deficits and may attribute their struggles to some delusional or hallucinatory reasons, and they cannot be left alone during that stage. Late or severe dementia, where the symptoms continue to progress and worsen. The scores will start falling on the Mini-Mental Status exam below 10. Patients will need assistance with all their activities of daily living and all their instrumental activities of daily living. 24/7 supervision is usually needed. Falls and wandering becomes much more concerning and much more frequent. You may notice some incontinence in urine and in stool. Sleep and appetite changes become much more prevalent and much more problematic. Motor deficits ensue later on, impairing their ability to move, to walk, and to swallow their meals. Food may need to be liquidized into puree forms, and you may have to consider other needs like using diapers, chucks, and so forth. So there are so many different scales that can be used to stage the dementia, but these are the three most common used in clinical and academic settings. The first one is called the CDR, or the Clinical Dementia Rating. The second is the Global Deterioration Scale. It's also known as Reisberg Scale. And FAST, which is the Functional Assessment Staging Test. And under this video, I'm attaching copies of these rating scales for your use. So, are all dementias considered the same? Is it just all about memory loss with some icing on the cake? Well, depends. It depends because there are several types of major neurocognitive disorders, which I will talk about in the next few slides, and they each present with different cognitive deficits. So as you can see in this slide, we have at least 16 known types of major neurocognitive disorders. The most common one is Alzheimer's disease, but you should also know about the other ones and be aware that there is a longer list of differentials when it comes to cognitive decline, especially in older adults. So I realize it's a lengthy list, 16 types is a little bit too long, but we can go through them bit by bit. For now, I'm gonna go through the most common type of major neurocognitive disorders or dementia, which is Alzheimer's disease. So how do we describe Alzheimer's? It's a slowly progressive neurodegenerative tauopathy that leads to brain cell death, causing impairment in functioning and cognition, ultimately leading to death. It is most commonly occurring after age of 65, with the incidence rate doubling every 5 years after 65. The most common early symptom is short-term memory loss, followed by visuospatial problems language difficulties, and disorientation. Behavioral changes are quite common, and it's also characterized in later stages by loss of bodily functions, ultimately leading to death. The staging is very similar to what we had discussed in previous slides. It comprises around 70% of cases of dementia worldwide, and the numbers, as we had mentioned before, are expected to triple by 2050. So the etiology of Alzheimer's disease is different depending on what type of Alzheimer's disease we're talking about. When we're talking about early onset Alzheimer's disease, where the onset of illness starts before 65, and that only comprises around 1 to 2% of all cases with Alzheimer's disease, it's mostly familial with an autosomal dominant inheritance, meaning that each generation in the pedigree will have at least one case affected by the disease. It is characterized by a much rapid progression, and there are some identified gene mutations leading to such a disease, like the amyloid precursor protein gene, the presenilin genes, and a high inheritance of the ApoE4 allele inheritance. Most will increase the load of the amyloid beta protein, which is responsible for formation of the toxic amyloid plaques that impairs neuronal function, leading eventually to neuronal cell death. There are other implicated genes in the early onset Alzheimer's disease, including the ABCA7 and the SORL1 gene. So the other type of Alzheimer's disease is the late onset Alzheimer's disease, which is mostly sporadic, not inherited. It starts after the age of 65, and the strongest genetic risk factor is having the ApoE4 defective allele. We have different types of ApoE alleles ranging from 1, 2, 3, and 4, and the ApoE gene is responsible for encoding a protein that should remove toxic amyloid from the brain. It has been discovered that the ApoE4 allele encodes a defective protein, causing a much faster accumulation of toxic amyloid in the brain, which we believe so far is the main culprit causing Alzheimer's disease pathology. So if you have one copy and you're heterozygous for the ApoE4 allele, you have 3 times the risk of developing Alzheimer's disease. But if you're homozygous for the ApoE4 allele, the risk increases to 15 times the general population. Non-genetic risk factors that causes late onset Alzheimer's disease include head injury, clinical depression, high blood pressure, diabetes, hypercholesterolemia, smoking in early life, air pollution, biometals in toxic doses, and there are some studies now examining if sleep disturbances in middle age puts you at a measurable risk to develop Alzheimer's later in life. So allow me to go quickly over the pathology of Alzheimer's disease and how it progresses. So first we'll talk about the amyloid plaques, which begins with the amyloid precursor protein, which creates a much needed transmembrane protein that is important in neuronal development, but it gets broken down by an enzyme called beta secretase and gamma secretase, creating amyloid beta peptides that are partially soluble. But if you have mutation in those genes, the amyloid precursor protein or the presend genes, you create abnormally long proteins, which are less soluble than the regular healthy amyloid beta peptides. These insoluble, abnormal, long peptides create oligomers that make plaques, and these plaques are quite neurotoxic because they activate local microglial inflammation, increasing a lot of oxidative damage, tau phosphorylation and dysfunction, and calcium-mediated excitotoxicity, leading to neuronal cell death and apoptosis. So these amyloid plaques cause neuronal dysfunction because the hyperphosphorylation of the tau protein which is a much needed protein inside the cell that helps the cytoskeleton transporting chemicals and neurotransmitters up and down the neuron, starts dissociating from the cytoskeleton, and the cytoskeleton cannot function as it's supposed to. And these are called the neurofibrillary tangles. They are basically made of hyperphosphorylated, unhealthy tau proteins. So that was talking about the microscopic aspect. When it comes to the macroscopic aspect, which we could see on brain scans like a PET scan, an MRI scan, we typically see atrophy in certain regions like the temporal cortex, especially the hippocampus, which is responsible for memory loss. The parietal cortex follows, which is responsible for the special sense praxis and some language issues. The frontal cortex, which in turn affects attention and executive functions, some of the emotions, and then the cingulate gyrus, which is responsible for motivation, and the locus cerealis in the pons will affect the mood, vegetative functions, and the level of alertness. So how do we diagnose Alzheimer's disease? Just to make this clear, definite diagnosis can only be made through brain autopsy. So after the subject dies, we get the brain, dissect it, examine it under the microscope, and we find the evidence for neurofibrillary tangles and the amyloid plaques. So what we can do while the person is still alive is a clinical possible or probable diagnosis that can be made, which depends on history, examination, neuropsych testing, and a lot of workup to confirm or exclude other possibilities for neurocognitive disorder. Some genetic testing can be helpful, like testing for the ApoE4 allele. And CAT scan, MRI with volumetric studies, the PET scan, the SPECT scan may also guide diagnosis as radiological biomarkers. There are also some FDA-approved radiopharmaceutical agents that can be used in the PET scans for Alzheimer's disease. So the diagnosis per the DSM-5 is 3 possible diagnoses. Either you have an evidence of neurocognitive disorder with genetic evidence like the ApoE4 or the other genes that may cause the early onset Alzheimer's disease that makes a probable neurocognitive disorder due to Alzheimer's disease. If you have a neurocognitive disorder with a typical onset and course of illness from the history taking, plus at least 2 cognitive deficits, plus functional disability, and you are able to rule out all the other plausible causes of this deficit, then we're also talking about probable neurocognitive disorder due to Alzheimer's. The last possibility, if you have a decline in memory and learning alone with functional disability, no genetic evidence, and the course of illness is a little bit atypical, then it is a possible neurocognitive disorder due to Alzheimer's disease, and we should consider other causes as well. So, unlike what you may think that Alzheimer's disease is the most common cause of cognitive impairment, but it is still a diagnosis of exclusion. You must exhaust all other possible etiologies first, because the definite diagnosis of such a disease is by brain biopsy. And that's why we mentioned in the previous slide that even if you have an evidence of neurocognitive disorder, you either back it up with genetic evidence, back it up with a typical course and a functional deficit and excluding other possibilities. If you don't have these elements, then you downgrade your diagnosis from probable to possible. So here's a diagnostic approach that I suggest in clinical settings. You start with a history, and you must include a reliable informant, somebody who's living with the subject, somebody who knows him, especially pre and post symptoms. Physical exam, including vital signs, neurological assessment, including speech and gait, cognitive testing, screening for depression because it can be a reversible cause of neurocognitive impairment, labs to rule out other possible causes like vitamin deficiencies, like toxicities, like drugs or illicit substances, these needs to be ruled out first. You need to do some brain imaging to confirm your diagnosis through radiological biomarkers and exclude other possibilities of the neurocognitive disorder you're dealing with. Some special tests may be indicated, depend on the diagnosis you're looking for, and you end at a probable diagnosis and a differential that may need revision as you start treatment. So what's the prognosis of Alzheimer's disease? Well, we're looking at a chronic progressive course despite all the efforts that we can make in a clinical setting. A third of the patients will show slow progression, the other third will show moderate progression, and the last third will show rapid progression and death within 5 years. Pneumonia and dehydration are usually the most common immediate causes of death. Survival is definitely affected by this disease. So at the diagnosis between age 60 and 70, the survival years are typically between 7 and 10 versus 15 to 23 for those who do not have the diagnosis. If the diagnosis was made at age 90, then we're looking at 3 more years of survival versus 4.5 years of survival. And men have a less favorable survival prognosis than women. So let's talk about the management of this terminal illness basically. There are no treatments, there is no cure yet, but there are goals of care that we should work through with patients and their families to improve their quality of life. The first one is care planning, second one is symptomatic treatment, the third one would be slowing the disease progression. So care planning involves occupational therapy, home care, placement if needed, like in an assisted living or a nursing home, planning advanced directives, and caregiver support, which is a new and a very important aspect of dementia care, including psychoeducation on the nature of the illness, nature of symptoms, how to deal with them, offering them their own therapy, support groups, helping them with financial planning, hooking them up with elder lawyers to handle the property, the finances, and how to allocate resources. Case management is almost often needed, and some may need treatment themselves. Some caregivers end up having a diagnosable mental illness due to stress, even if it's just adjustment, and they need treatment themselves. Next is the symptomatic treatment of behavioral symptoms of Alzheimer's disease. And we could use different modalities like behavioral management using the ABC model, which is short for antecedent, behavior, and consequences. Therapy modes like reminiscence therapy, validation therapy, supportive therapy, and sensory integration therapy directed towards the subjects suffering from Alzheimer's disease. There are pharmaceutical agents that can help us mitigate some of the behaviors. For depression and anxiety, we could use antidepressants. For compulsive behaviors, we could use SSRIs. Sleep is a big component that needs a lot of attention and can benefit from a lot of pharmaceutical and behavioral interventions. Psychosis and aggression may benefit from SSRIs and antipsychotics. Mania may benefit from antipsychotics and mood stabilizers. Last but not least is exploring options that can slow the progression of the disease, including health optimization, non-pharmacological treatments, and pharmacological treatments. So health optimization, meaning optimizing the other aspects of the patient's health other than his cognition, including his vision, his hearing to optimize the input from the external environment, examining their medication, their general medical health, examining their mobility, making sure that they can walk safely. And smoking cessation is also important because it has been found that particularly those with the ApoE4, smoking can be quite detrimental to the progression of Alzheimer's disease. Non-pharmacological may include diet adjustments, sleep hygiene, exercise, increasing social activity, and some benefit from cognitive rehabilitation, using cognitive exercises. Last are the pharmacological interventions, including cognitive enhancers and monoclonal anti-amyloid agents. So let's talk a little bit about the monoclonal anti-amyloid therapies. So these are the most recent disease-modifying agents on the market, have been in development for the past 17 or 18 years, and these are basically lab-created antibodies that flag the toxic beta amyloid in the plaques for removal by the immune system of the brain. The first one that was FDA approved was the aducanumab, which is also called Aduhelm, in June of 2021, and there are several other more in the pipelines. These compounds are currently indicated for mild cognitive impairment or early dementia due to Alzheimer's disease, which means that the subject should show screening scales showing measurable cognitive deficits in at least one domain, plus biomarkers of Alzheimer's disease, which I will discuss on the next slide. The three known compounds so far are the aducanumab Aduhelm, but it was discontinued by Biogen in January 2024 for financial reasons. The lecanemab, which is also called Leqembi, is the one currently most popular in the field. The third one, which is still pending FDA approval, probably later in 2024, is called donanemab. So there are several side effects, but the most remarkable ones that we are always monitoring and should be aware of are infusion-related reactions happening at around 20% of cases with Leqembi, the amyloid-related imaging abnormalities that classified in two types, ARIA-E, which relates to amyloid-related imaging abnormalities in the form of cerebral edema, and ARIA-H, which are amyloid-related imaging abnormalities in the form of microhemorrhages. The cerebral edema is more likely to happen with higher doses, rapid titration, and those with ApoE4 alleles, whereas the hemorrhage happens more in those who have a history of cardiovascular accidents and advanced age. There are also trials ongoing using the same compounds but for other stages of Alzheimer's disease, including preclinical Alzheimer's disease, who have positive amyloid in their scan. They're showing the biomarkers, but they don't have any symptoms at all. And they do not have measurable deficits in their cognition. And this is as of March of 2024. So what are the biomarkers for Alzheimer's disease? So what are the biomarkers for Alzheimer's disease? We have two groups. One is considered suggestive of Alzheimer's disease, pointing to the need for further investigation. These include the ApoE4 allele. If you have one or two copies, makes you more likely to have Alzheimer's disease if you're suffering from any cognitive deficits that are measurable and interfering with your functioning. The second one is using brain imaging like a CAT scan or MRI with volumetric measures and examining if there is some regional atrophy, especially if it's affecting your parietal and your temporal lobe. Third is using a PET or a SPECT scan to look at the local reduction in metabolism, especially it's affecting your parietal or temporal lobes. These would point you to pursue further testing and see if the subject may benefit from these anti-amyloid monoclonal therapies. These include the amyloid PET scan, which basically examines the load of amyloid in the brain, and these are now covered by Medicare as of January 2024, which wasn't the case last year. Lumbar punctures and examining the ratio between the p-tau and the A-beta 42 protein, and if this ratio is higher, means that the load of the amyloid in the brain is higher than what the ApoE protein can remove. and it's covered by some of the insurance plans, but not all of them. And there are newer blood-based biomarkers for Alzheimer's disease that are not commercially available yet, including the plasma p-tau 181, 217, and 231. So that brings me to the last slide of this section, in which I'd like to shed some light on the trajectories of Alzheimer's disease with anti-amyloid therapies. And bear in mind that the data that we have so far is quite limited because these compounds are fairly new. The preliminary data that we have so far shows that with MCI, we basically buy them around 8 months or more before they start slipping into early Alzheimer's disease. When it comes to early Alzheimer's disease subjects, they either get benefit for around 6 months, some of them will get the benefit for about 2 years, and surprisingly, there is a small subset of those subjects who actually stay at a plateau for much longer than 2 years before they start deteriorating into moderate Alzheimer's disease. And there are so many studies going on to try to examine why subjects respond differently to these same compounds. Thank you so much for paying attention so far through this lengthy and dense module. And I hope I see some of you in the next section where I discuss in detail more of the other types of major neurocognitive disorders affecting older adults.